to Sovah Health computer systems through our website, the Sovah Health website. If you go there and click on the education tab, it will take you to a link that will allow you to listen and watch these recorded programs. These recordings do not provide CME or CE credit. They're not designated as what are known as enduring CME materials, but we welcome you to watch them or your associates if you find it of interest to you. The learning objectives for this program this evening, which is one of two programs this month on adolescent medicine, is that we hope you will have improved competency at the end of the program to recognize and medically manage adolescent eating disorders, including anorexia nervosa, atypical anorexia nervosa, bulimia, avoiding restrictive food intake disorders, orphan binge eating disorders, and some other things that our speakers will be covering this evening. The program provides 1.5 hours of Category 1 AMA physician CME credit and 1.5 hours of Virginia Nurses Association CE credit. Sovah Health is accredited by the Medical Society of Virginia and the Southeastern Coalition for CME to provide medical education for physicians. And Sovah Health is also accredited by the American Nurses Credentialing Center Commission on Accreditation through the Virginia Nurses Association to provide nursing CE credit. The program was developed to promote several desirable physician attributes, including our providing patient-centered care, patient care that's compassionate and effective, and patient care based on medical knowledge. Dr. Louis Jacques, Dr. Stevens, myself, and members of the Sovah Health CME Committee have no commercial relationship disclosures to make to you. There is no commercial support for this program this evening. It is supported by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. This fund, provided by Dr. Landis upon his clinical retirement a number of years ago, provides funding for a speaker honorarium and travel for different types of CME programs for all types of allied health as well as physician healthcare providers. It's a program that's unique in the United States and one for which we continue to be grateful to Dr. Landis for his foresight in providing this. This evening after the program, or either first thing in the morning, Mary Kent will email to you an evaluation form. It requires you, in order to complete it, which we thank you for doing, that you re-enter your name and email address. Please, please, please put your real name on this evaluation form email. Please don't give us a nickname, a cute name, or anything of that nature, since the name that we get on this eval form is what will be on your CME certificate. And in addition, Mary has to make sure that she gets the CME certificates back to you once it's done. When you fill those out, I bring your attention to the fourth question, which the question reads, what changes will you make in your practice based on what you've learned this evening? That is meant for everyone who's kind enough to fill out an evaluation form, not just for the providers. We all practice our healthcare skills within our scope of practice, and take a few minutes and tell us about that. You will receive your CME certificate electronically once we get the eval form back. The eval form is not required of you to get your certificate. If you feel you do not want to do an eval form, please email myself or Mary or Camilla Deal for nursing and nurse practitioners, and we'll see that you get your certificate. For the many residents on the call tonight, and I would take a moment just to welcome our new class of internal medicine and family medicine residents. We're glad you're with us this evening. We're so pleased that you chose Sovah Health as a place to do part of your training to become a practicing physician. Your coordinator, your program coordinator, Dara Johnson or Lori Galvez, will track your participation in the program this evening as is required by your respective programs. At this point, every time I like to just extend a very special thank you to Mary Kent. She makes all this happen. doing all the document management and the electronic relationships that are needed for us to have the call this evening, and to Camilla Deal, who does the same for us for the nursing CE credits. Without their great, generous help, we could not do these programs. We like to make the providers, the doctors on the call tonight, aware that we do use the passport system within the program and activity reporting system, nicknamed PARS, to track your participation for CME. In order for us to enter your name and your participation this evening, you have to give us permission on a one-time basis, including some special personal information shown here, name, birthday, or month, and licensure states, so that we can submit that to you. At the end of the eval form, there's a permission form. If you've not yet completed one of those and would like us to track this in Passport for you, if you've done it once anytime in the past year, you do not have to do it again. The reason this is terribly important, if you're a surgeon on the call this evening, is that 4 boards are currently tracking Passport recorded participated CME for their board renewal process: general surgery, ENT, orthopedics, and thoracic surgery. They no longer allow self-reporting of completed CME for board renewal. All the other subspecialties, you continue to do that self-reporting as you've done before. The speakers tonight have asked that you hold the questions till the end of the presentation, so make a note, and we urge you to actually do that at the end of the program. Mary Kent will be monitoring the chat throughout the evening if there are messages coming that way. I will point out that during this program, there are 3 speaker audience response questions, and the speakers will explain to you how to respond to those. If that system doesn't work, and we hope it will, we have no reason to believe it won't, but if it doesn't work, we'll fall back on the chat for responses. The speakers will explain that when they get to their audience response questions. I want to remind you of 2 upcoming programs. One will be, as you see here, in August. This program will focus on interpersonal violence between healthcare professionals, recognizing and managing it, with Dr. Michelle Patch from the Johns Hopkins School of Nursing, and Dr. Peter Hill, who's the Chief Medical Officer at the Johns Hopkins Hospital also. The other program that will be occurring in 2 weeks from this evening is the second in the Adolescent Health Program series for July. And this one will address common mental health issues in adolescents with Dr. Stevens from the UVA Pediatric Department, and then adolescent gynecological disorders with Dr. Susan Gray, who also is at UVA. That being said, both of our speakers tonight, as well as the 2 for next week, our next program, July 25th, are from the Division of Adolescent Medicine at the University of Virginia within the Department of Pediatrics. I want to take a moment and introduce these excellent teachers to you, so you'll have some insight about their experiences. Dr. Jennifer Louise Jacques, originally from New Jersey, received her undergraduate degree in biological sciences from Cornell, and then completed a master's in public health from Columbia University School of Public Health. She then did her MD degree from New York University, followed by pediatric residencies at the Morgan Stanley Children's Hospital of New York, which is part of the Presbyterian Columbia system. If you're not familiar with New York and pediatric hospitals in general, Morgan Stanley's hospital is one of the top-ranked pediatric care facilities in the United States. She followed this formal pediatric training with adolescent medicine fellowships at Boston Children's Hospital, and then had a tenure at the Children's Hospital of Philadelphia as an attending, where she was the director of outpatient adolescent medicine rotations. During her careers prior to coming to Duke, she's been a Harvard Macy Institute scholar, and UVA, excuse me, Dr. Louise Jacques, and indeed she currently is a faculty coach for Foundations of Clinical Medicine at UVA. The second speaker, Dr. Sarah Stevens, is from Florida originally. She received her undergraduate degree in psychology from the University of North Florida, graduating summa cum laude. She then completed both her master's and PhD in social work from Florida State University. Her clinical care training was done at Providence St. Vincent's Hospital in Portland, Oregon. She has had a really unique career. She participates in the developing of content for testing for the Association of American Medical Colleges in the area of situational judgment, and also for the adolescent medicine content for the American Board of Pediatrics. Finally, she has one other unique skill set. She has been a formal legal victim advocate in the Florida State Victim Advocate Program. In doing that, she travels and goes to court and legal hearings and court appearances, etc., for individuals with different disorders and problems, and helps them make their way through the complex world of the legal process. This evening, the two speakers are going to together do this presentation for us. So I am going to, at this point, take my slides down, and I would ask Dr. Stevens to go ahead and bring yours up. You basically will knock me off, so to speak, and we should be able to get going.
Okay.
There you go.
All right.
Looks
Can you
great.
see that?
Thank you.
Great.
Yes, ma'am. Thank you so much.
Wonderful. So thank you so much for that lovely introduction. I'm here with Dr. Louis Jock today, and we're going to go back and forth to talk about eating disorders, recognition, and management.
So much for that brief introduction, Sarah, and thank you, Michael, for that wonderful introduction. Sarah and I are so happy to be here to talk with you guys today about this important topic, and we hope that you'll feel really empowered to be able to take care of this population at the conclusion. But I'd like to go over the lecture objectives real quickly. By the end of this lecture, we'd like you to be able to recall the differential diagnosis of eating disorders, select the appropriate initial laboratory evaluation, identify medical complications associated with eating disorders, identify patients meeting criteria for inpatient medical hospitalization, describe the levels of care for ED treatment, identify the appropriate level of care for ED treatment, discuss treatment approaches for EDs, including family-based treatment, and finally, explain the importance of ED prevention to primary care practices.
What we're not going to cover today are weight loss surgeries, weight loss medication, or weight loss recommendations. This is a different field. We certainly work with individuals who live in larger bodies, as eating disorders affect individuals regardless of body size and shape. Our focus is on behavioral changes to include a wide variety of foods from all the different food groups, and to ultimately reduce focus on body size and shape. So we'll talk about this briefly in our prevention efforts.
This is the audience participation portion of the talk. We'd like to get a sense of what you guys think when you hear the term eating disorder. So you should be able to, give me 1 second. Oh, the instructions are not showing. So I think we'll just have to utilize the chat because the instructions and the QR code are not showing up. So if you could type in the chat some of the words or phrases that come to mind when you hear the term eating disorder.
Are either of you able to see the chat on your screen?
Yes.
Okay.
So thank you all for contributing and having those thoughts. I think all those are really valid terms that come to mind when you think about eating disorders. Other ideas or thoughts that can come to mind are it's due to overbearing parents or it's a white rich girl problem. But it's unlike other conditions, eating disorders can bring up a lot of emotion, judgment, frustration, perplexion. It's like, why can't you just eat? So it can be really frustrating. So it's really important to recognize our own biases when we take care of these patients so we can provide optimal, appropriate care with empathy.
So in order to demystify eating disorders and talk about some of where these biases come from, it's really important to go through its history. So here's a brief lesson. Eating disorders, as defined by self-imposed food refusal, have been present for a long time. The first documentation of eating disorders is from the Middle Ages, which was focused on spiritual purity instead of drive for thinness. It was explained by holiness and sometimes referred to as holy anorexia. 1873, the term anorexia nervosa was coined in a medical presentation where females refused food, resulting in an emaciated body and amenorrhea. Bulimia was named in 1979 when a British psychiatrist coined the term. And then anorexia officially appeared in the DSM in its third edition in 1980. And then bulimia was listed in the revised DSM-3 in 1987 as a standalone diagnosis. So early beliefs were that eating disorders only affected affluent young girls. Hilda Bruch wrote The Golden Cage in 1979. She was a psychiatrist and psychoanalyst known foremost for her work on eating disorders and obesity, and she really pioneered this belief. And in her book, she wrote, "New diseases are rare, and a disease that selectively befalls the young, rich, and beautiful is practically unheard of. But such a disease is affecting the daughters of well-to-do, educated, and successful families, not only in the United States, but in many other affluent countries." So a recent large systematic review of the literature found that there's no pattern of evidence for relationship between higher SES and EDs. EDs present across a wide range of socioeconomic backgrounds, and there's an urgent need to prioritize accessible eating disorder treatment, and more research is needed on barriers to treatment with those with lower SES. So the ramifications of these beliefs are that individuals with lower SES are less likely to receive proper screening and treatment for eating disorders. Specialized mental health services are often less accessible due to the high direct and indirect costs of participating in such care. And when people with lower SES do seek services, they may face longer wait times and receive lower levels of care and attention from providers. Clinicians may also be less likely to inquire about and correctly diagnose eating disorder symptoms in those whose identities defy illness stereotype. So this results in a circular problem where eating disorders in individuals with lower SES are not accurately identified, which reinforces false beliefs about eating disorders and in turn shapes research and treatment priorities. And the association between SES and racial and ethnic disparities complicates this issue, as racism and racial discrimination also contribute to the inequities in healthcare. Another early belief of eating disorders were that families were to blame. During the 1960s and 1870s, a crucial role of family environment was postulated, and an anorexogenic family was associated with the development of anorexia. Again, Dr. Bruch highlighted overbearing parents, especially over-controlling mothers, and noted that the individual with anorexia turns to extreme control over her body because everything in her life appears out of control. Even in the last 25 years, there have been many studies highlighting the different family structures related to different symptomatology, which suggests an association of enmeshed family environment and severity of restrictive eating, and also suggested that the disengaged family environment might have an association with binge eating. Ramifications of this were that early treatments did not involve parents or family, and treatments were often limited to inpatient and residential facilities. And since parents were often viewed as over-controlling and the eating disorder was a response to regain control, parents were advised to not talk about food or monitor intake. And there were discussions that food is not the problem, and psychotherapy approaches were focused on underlying issues and searching for the cause of the eating disorder rather than utilizing the family for practical support with refeeding. So here's the DSM-4, which was the authority for diagnostic criteria from 94 to 2013 until the DSM-5 came out. So there was tremendous awareness of eating disorders during this time period, and there have been many treatment programs, treatment interventions, and research based on this categorization system. And this has led to many limited beliefs about eating disorders. So during this time, anorexia nervosa also had the two types, restricting type and those that engage in recurrent episodes of binge eating or purging behaviors, refusal to maintain at least 85% of quote normal body weight, or having a BMI of less than 17.5. So they had a weight criteria and cutoff, an intense fear of gaining weight or becoming fat, and also a disturbance in the way in which one's body weight or shape is experienced, an undue influence of body weight or shape on self-evaluation. They also had amenorrhea, which was defined as 3 months of missed periods. Bulimia nervosa is recurrent episodes of binge eating and purging, but individuals remain at or above a quote normal weight. And then they had what was called eating disorder not otherwise specified, or the EDNOS category. They had eating disorders of clinical severity, but they do not meet the full diagnostic criteria for anorexia or bulimia. The EDNOS category also mentioned binge eating disorder. There were a lot of issues with this DSM-4 criteria because most of the individuals were in that EDNOS category. The amenorrhea criteria was not applicable to males, pre-pubertal, postmenopausal women, and women using hormone replacements. So all those with anorexia who didn't fit that were in the EDNOS category. And the weight criteria was also limiting individuals who had higher BMI at baseline. We also know that weight criteria is stigmatizing, furthering misinformation that only the thinnest are sick enough. Insurance companies were also less likely to provide coverage for care for individuals in the EDNOS categories. And I also want to be clear that eating disorder treatment was really difficult for most patients to get during this time frame because mental health parity laws didn't exist. So there were limits to 30 days for inpatient a year, outpatient therapy was often limited, etc. So the Mental Health Parity and Addiction Equity Act came out in 2008, and it was really groundbreaking in terms of increasing the access for all mental health and substance use disorder treatment. And this was strengthened in 2016 to explicitly state that eating disorders must be included in this. So just getting access to care has been an ongoing struggle, and spoiler is that we have not gotten close to solving this problem, especially for patients in marginalized communities and those with state-funded insurance. The DSM came out in 2013, and this is our current classification system. So there have been some improvements. So for anorexia nervosa, we remain the abnormally low body weight, an intense fear of gaining weight, and a distorted perception of weight. They did remove the weight criteria and changed it to restriction leading to a significantly low body weight, including a failure to make appropriate weight gain in growing children or adolescents. And they also dropped the amenorrhea criteria. Bulimia, they also loosened criteria regarding to how often someone engages in binge eating and purging behaviors. And I do like to highlight the only difference between bulimia nervosa and anorexia binge purge subtype is the weight status. So if an individual is technically underweight, they would be anorexia binge purge, and if they are normal weight or above that, it would be bulimia nervosa. Binge eating disorder was added in the DSM-5 as a standalone diagnosis, and this is where we have recurrent episodes of eating large quantity of foods, feeling a loss of control, shame, distress, or guilt afterwards, and not engaging in any unhealthy compensatory measures. And so it's important to differentiate between subjective and objective binge eating when talking with individuals. Oftentimes, individuals with eating disorders will talk about binge eating, and then when you ask more clarification, maybe it's just a normal meal. So getting some clarity on that. And also knowing that many individuals with other eating disorders often engage in some binge eating episodes because the number one cause of overeating or binge eating is undereating, dieting, or restricting. Also, another new diagnosis for the DSM-5 was avoidant restrictive food intake disorder, or what we call ARFID. And this is when individuals are not eating enough, and that results in one or more of the following: a significant weight loss or the failure to achieve the expected weight gain, significant nutritional deficiency, or a dependence on enteral feeding or oral nutritional supplements, or a marked interference with psychosocial functioning. So the reason that individuals are not eating are one of the following: either sensory sensory-based, that's somebody being really picky with texture and taste. Trauma-related, so maybe they had a choking incident and now they're scared of eating, or perceived GI distress or discomfort when eating, or apathy around eating or poor appetite. The differential from anorexia is that there's no body image concerns as seen in anorexia. Typically, there's no fear of gaining weight. Often individuals want to gain weight, or they're at least indifferent to it. So there are also a host of other specified feeding or eating disorders, what they call OSFED now. And the one that is most often seen clinically is atypical anorexia. And we've learned a lot about atypical anorexia over the last 10 years. I'm going to spend some time walking through it since it's often a pretty misunderstood disorder. So atypical anorexia describes individuals who meet all criteria for anorexia, except that despite significant weight loss, their weight is in the quote normal or above normal range. So there's a lot of questions of what is significant weight loss. Forney and colleagues in 2014 helped us define this, and they did a study, and they found that even a 5% weight loss combined with cognitive concerns may produce a group with a clinically significant eating disorder. They also found that atypical anorexia was observed in both healthy weight and overweight or obese adults, highlighting the importance of screening for restrictive eating disorders at all weights. And Garber and colleagues in 2019 looked at illness severity between those with anorexia and atypical anorexia, and they found that those who experienced a greater amount, rate, or duration of weight loss had significantly worse medical and nutritional status independent of admission weight, so whether it was technically underweight or someone who was average or overweight. And the eating disorder psychopathology was significantly worse in atypical anorexia, which is in accordance with prior studies. So the marked rise in individuals with atypical anorexia requiring hospitalization at apparently normal weights has challenged the historical reliance on current weight to guide clinical concern. Findings from many studies that highlight the need for early intervention regardless of body weight, and also highlighting that diagnosis is often missed because the current weight is in the normal range. So more on atypical anorexia. Individuals with atypical anorexia often face weight-based discrimination. Patients are often praised for weight loss and making healthier choices, reinforcing eating disorder behaviors and beliefs that their body size and shape is a problem. A quote from a patient is that my doctor told me my weight was going up a little fast and told me I should eat healthier. So I started counting calories, exercising hours a day, and I lost 45 pounds in 4 months. At first I was praised, and then I was sent to the eating disorder treatment team and told I was needed to be hospitalized for malnutrition. Patients receiving care often struggle with getting insurance to cover for higher level of care. Insurance companies continue to rely heavily on BMI to track progress, and so they discharge patients in higher weights quickly. And also, patients diagnosed with atypical anorexia experience significant weight bias from providers, family, friends, and sometimes even treatment centers. So here's some quotes. You're not underweight, you don't have an eating disorder. In fact, you could still lose some weight, said by a provider. We're worried she might gain too much weight and be obese again, from parents. I would absolutely kill myself if I got fat. And this was said by a patient in a residential treatment in a group with individuals in larger bodies.
Thank you so much, Sarah, for giving us that background on the different types of eating disorders and the criteria. So now I'd like to transition to recognition of eating disorders in the primary care setting. So how do we spot eating disorders in a primary care setting? Assessment is really important. Any developing child or adolescent who presents with weight loss should trigger concern in you. That's worrisome and should warrant further investigation and monitoring. So first you're going to review growth charts, and then you're going to investigate these 3 different areas. First, body image, and listed on the slide are some questions you can consider asking, such as, tell me about your thoughts about your body. Reviewing a dietary history and eating behaviors. Have you tried to change how you eat? Tell me what you eat in a typical day, and do you feel guilty for eating? And finally, exploring a little bit more about exercise history. type, frequency, and intensity. So some questions that can be helpful for assessing that is how stressed you feel when you're unable to exercise, and if they've ever had overuse injuries and been advised to take a break and they've been unable to do so. As you're exploring further what has been going on with the weight loss, it can be helpful to talk with the parent or guardian separate from the adolescent to explore a little bit more. So on the slide are some questions you can consider. So I'll give you a minute to kind of take a look at that. Malnutrition impacts nearly every system in the body, and I'm going to go through shortly all the different systems in the body that are impacted by malnutrition. But as a result of this, oftentimes patients themselves or they're brought in by a parent or guardian with specific complaints that actually are a consequence of malnutrition. So on the slide are some examples. So complaints of inability to focus, having trouble with memory, early satiety or constipation, slow heart rate, low blood pressure, feeling lightheaded or dizzy, cold intolerance, and easy bruising. So these complaints sometimes are actually a signal that malnutrition may be at play.
So I often get asked by providers if a patient has ARFID or anorexia, or what, right? Because a patient is not expressing body image concerns or denying the eating disorder. My short answer is that I don't care if it's anorexia or ARFID. Pediatric or adolescent patients who are ambivalent about recovery from their eating disorder are often not forthcoming with their reasons for food restriction. So if a patient has weight loss and the patient or parent report indicates that the patient is not eating enough routinely and medical causes have been ruled out, then
Right.
it's safe to assume that the
Right.
patient is struggling with an eating disorder.
Oh, I can't stand it. Sometimes. Yeah.
It sounds like someone is not muted. Thank you.
Please mute your
I got
phone
it.
and-
It's muted.
Thank you. So some scripts to say, right, you're not eating enough for your body to function well and to continue to grow and develop. And I think you have an eating disorder. We need your parents or caregivers to help make sure you're eating enough. We're putting them in charge of your food intake. This may be difficult, and having a therapist can help you work some of these challenges of eating more. So the initial care for eating disorders, whether it's ARFID or anorexia, will not change. The first step is always normalizing eating behaviors, so having routine eating throughout the day and eating enough. We're going to empower parents and caregivers to take over feeding, which we'll talk about later. And we're also going to consider a referral to higher level of care if we're unable to make progress. Eating disorder programs are equipped to manage the wide spectrum of eating disorders, including ARFID. And if weight gain causes body image distress, then it's likely anorexia, and it'll be important to address body image distress in therapy.
So we're going to utilize the chat again, and we would love to hear from you guys, your thoughts on what causes eating disorders.
Dr. Louis Jock, if you don't mind reading some of those that come in, I don't see them on my side.
Sure. Low self-esteem, trauma, body image, lack of perceived autonomy, environment, weight bias, controlling parents.
Awesome. Thank you so much for all those. You're all correct, right? What causes eating disorders is very complicated. There's not one thing that causes an eating disorder. We know it's a complex interplay of biological, psychological, and social environmental factors that come together as a perfect storm for the development and maintenance of an eating disorder. And so in treating eating disorders, we don't spend time figuring out what caused it, but rather what's maintaining it and intervening from there. We're going to go through the 9 truths about eating disorders that was developed by the Academy of Eating Disorders to share with patients, family, and providers. Truth one, many people with eating disorders look healthy, yet may be extremely ill. 2, families are not to blame and can be the patient's and physician's best allies in treatment. 3, an eating disorder diagnosis is a health crisis that disrupts personal and family functioning. 4, eating disorders are not choices, but serious biologically influenced illnesses. 5, eating disorders affect people of all genders, ages, races, ethnicities, body sizes and shapes, sexual orientations, and socioeconomic statuses. 6, eating disorders carry an increased risk for both suicide and medical complications. 7, genes and environment play important roles in the development of eating disorders. 8, genes alone do not predict who will develop eating disorders. And 9, full recovery from eating disorder is possible, but early detection and intervention are very important.
I'd like to just share with you guys some numbers to think about. According to the National Association of Anorexia Nervosa and Associated Disorders, 30 million people of all ages and genders suffer from an eating disorder in the United States. When we think about the pediatric and young adult population, a 2010 longitudinal study that followed girls for 8 years showed that 5.2% met criteria for an eating disorder. This increased to 13.2% when non-specific eating disorder symptoms were included. 41.5% of female athletes in athletic sports, such as figure skating and gymnastics, reported disordered eating, and 40 to 60% of elementary school girls expressed concern about weight or becoming too fat. And finally, patients aged 15 to 24 with anorexia nervosa have a 10-time increased risk of dying compared to same-age peers. Eating disorders have the second highest mortality rate of any psychiatric illness. And this slide is just meant to emphasize the point that the prevalence of eating disorders is increasing, and we really saw an uptick with the onset of the pandemic. So we talked a little bit about what are the different types of eating disorders, why it's important to identify. And so I thought it would be helpful to go through a case to illustrate some of those points. So let's talk about Trevor. So Trevor is a 15-year-old male member of the high school cross-country team. The coach told him that if he improves his PR, he can make state finals this year. He's currently running about 6 to 7 miles each day, sometimes limited by abdominal cramping or nausea. He comes to see his team's athletic trainer for advice on how to increase his distance given his stomach upset. And his family also makes an appointment with the PCP-U to assess these concerns. Upon further assessment, you get a little bit more information. So Trevor actually has been restricting to about 1,000 calories per day, and he's been drinking a ton of water. He also has been vomiting. Initially, it was intentional, purging, but now it's kind of become more spontaneous and just happens all the time, up to 15 to 20 times per day in the past week. So now we're getting concerned and we decide to do a little bit more investigation. So we pull up the growth curve and take a look, and we see some concerning information, specifically the drop in his weight. And here's the corresponding anthropometric data. Of note, at this weight and with this data, Trevor is running his best times yet, and he is really not interested in making any changes. So one thing I wanted to pause on now is just to talk a little bit about BMI, median BMI, just because those terms are thrown around a lot when we're talking about eating disorders and how to assess how ill someone is or how malnourished. So as a reminder, BMI is weight in kilograms divided by height in meters squared. And the median BMI refers to the 50th percent BMI for a patient's age and gender. To calculate the percent median BMI, you're going to divide the current BMI by median BMI, multiply that by 100, and you'll get the percent median BMI. So as an example, if the current BMI is 16 and the median BMI is 21.8, this patient's percent median BMI is 73%, so quite malnourished. How do you calculate or how do you figure out median BMI? There's two ways you can do it. You could just pull up the BMI growth curve and find out what 50th percentile is and kind of trace over, but that gives you like a kind of a guess and not accurate. I like precision. So I actually utilize the CDC's website, the BMI percentile calculator for children and teens. And so if you Google this, you'll be able to pull up this calculator. All you need to do is input the information, patient's date of birth, the date that you got the measurements, their weight and their height, and it will spit out the current BMI for you. Then you play with the weight and that you'll be able to figure out the 50th percentile. So I like using this calculator because it can give me an exact median BMI like 20.4 or 31.6, and I prefer that. But using the growth chart is perfectly applicable or acceptable. So we have a 15-year-old who has a significant weight loss, intentional, unintentional. He's having symptoms of regurgitation and vomiting. So what is on our differential? What should we consider? And this is going to shape how we go through our H&P to get information. So on the slide, you're going to see what we would consider the broad categories for someone with malnutrition or weight loss. So thinking about the category of malabsorption, such as IBD or celiac disease, or a hypermetabolic state, such as a malignancy, or inadequate intake, so food insecurity, depression, or an eating disorder. So on this slide here, this is our other audience participation, but these are some labs you can consider getting at an initial workup. What do you guys think you would want to order for this for Trevor? And please just put in a chat. Yeah, I saw someone typed all of these, and this, yeah, all of these would be perfectly reasonable to obtain at an initial visit. If you have the ability to have close follow-up with the patient, you might want to do it in a staged manner, but all of these will help you work through that differential. I wanted to give you guys another way to think about the differential besides just memorizing categories. So a nice way to think about it is like a car and an engine and fuel. So either you're not putting enough fuel into the tank, or you have enough fuel, but the engine is not able to utilize it, or for some reason that engine is burning through the fuel super fast. So for not putting enough fuel in the tank, listed are examples that we talked about. So food insecurity, eating disorders, something that's making painful eating, and other psychiatric illness such as depression. For the engine not being able to utilize the fuel, this is where you can think about malabsorption, celiac disease, CF, and finally for burning through fuel, something that you can consider as an inflammatory condition, hyperthyroidism, a malignancy, or chronic infection. To summarize, this is what an initial visit for workup of malnutrition should look like. With an initial visit, our aim is to assess for medical stability and complications and work through our differential. So we're going to do that thorough H&P to figure out what should we be considering. Then we're going to check for instability by checking orthostatic vital signs. So that's the blood pressure and the heart rate, lying supine, and then after standing for 2 minutes, obtaining a weight and height so you can calculate BMI, and you're going to obtain the weight after voiding and with the patient in either a gown or a lightweight t-shirt or underwear. If the patient is bradycardic, you would want to consider getting an EKG, and then you would want to do the laboratory workup. So screening for other medical diagnoses, CBC, ESR, TSH, assessing for electrolyte abnormalities, and then checking a UA for water loading. So patients with specifically with eating disorders often will consume large amount of water to either falsify their weight or to make themselves feel full. So checking a UA and the specific gravity can help you assess that. So now I'm going to go through all the different systems in the body and what are the complications that we can see related to malnutrition. It's a lot of information, but I think the point of this is to show you that malnutrition kind of rears its ugly head in various situations. And so you will always want to keep it in the back of your mind. So the GI system is one system that's affected. Constipation, gastroparesis, elevated transaminases, and SMA syndrome. And this is because if there's a loss of the fat pad, and as a result, the superior mesenteric artery will get compressed and a patient will experience abdominal pain. If purging is occurring, you can see parotid hypertrophy, and the classic faces is shown in this picture here. We call it like chipmunk faces, so they have a very round appearance to their face. And listed on the slide are other examples of complications you can see with purging. The hematologic system is affected as well. I like to think about malnutrition slowing things down. So with the GI system, it slowed things down such that a patient has gastroparesis or constipation. And similarly, the bone marrow kind of gets slowed down. So it's not functioning as well because of malnutrition. As a result, it's not able to produce white blood cells, red blood cells, platelets, and as a result, you can see leukopenia, anemia, and thrombocytopenia. Some patients, all three cell lines will be down. Sometimes it's just leukopenia. The renal system is not spared as well. The kidney itself can be impacted, and you can see that manifests with an elevated creatinine. It's a form of AKI, and then the kidney itself will not function, and so there'll be dysfunction. You can actually see patients have an increase in urinary output because the kidney loses its ability to concentrate urine. You'll also see decrease in phos and potassium and glucose as a result of this dysfunction. Also, BUN and creatinine can be elevated because sometimes on the opposite spectrum, instead of water loading, sometimes patients with eating disorders will restrict fluid intake or not want to drink a lot. So you can see an elevation in BUN and creatinine. And then edema, which is associated with refeeding syndrome, which I will discuss shortly. The cardiovascular system is probably the system that's most obviously impacted in what we see oftentimes right away and often leads to hospitalization. You can see bradycardia, arrhythmia, EKG abnormalities such as prolonged QTC. There's postural orthostasis, so you'll see a rise in the heart rate when the patient goes from lying to standing of 30 beats per minute or more. You can also see decreased myocardial contractility and mitral valve prolapse, and this is because there's actual loss or decrease in cardiac muscle mass. Further complications later on can be heart failure or pericardial effusions. There are endocrine complications of malnutrition, so primary or secondary amenorrhea, pubertal delay, growth retardation, and short stature. And we can often see these if the malnutrition develops during the school age period. And then 6U thyroid syndrome is also seen. Here are some of the complications that we can see impacting the neuro and psych systems as well. Some of these are complaints that patients will bring to you, such as decreased concentration and memory, emotional lability, depression, anxiety, and rigid thinking. You can also see peripheral neuropathies, which develop as a result of deficiencies, as well as seizures and structural brain changes that are not always reversible. To speak a little bit more about the impact of malnutrition on the brain and the nervous system, I mentioned changes in kind of the appearance of the brain. So you can actually see brain atrophy. In anorexia nervosa, there's loss of gray matter, and in bulimia, there's loss of cerebral surface. You can see cortical limbic abnormalities, which impact appetite. So the anterior insula integrates sensory aspects of eating, and so with these abnormalities, there's an impact or a change in appetite. And finally, there are changes in the reward circuitry. In binge eating disorder, there's an increase in gray matter volumes, and that can be associated with the regions that are involved in reward learning. And in anorexia nervosa, we like to think about the restrictive eating as almost becoming like a habitual behavior or pattern, and this is a result of an increase in the dorsal striatum function. And finally, there are changes in neurotransmitter and hormonal function. Next system, the musculoskeletal system. So we'll see muscle wasting and then an impact on bone health, specifically a decrease in bone mineralization. And that is not always fully reversible. And as a result of that decrease, you are at increased risk for fracture. I talked about it not always being fully reversible. So studies have been done and it's like, well, maybe we'll just give OCPs. They have estrogen. Estrogen helps with bone mineralization and studies show that that doesn't restore bone mineral density. Bisphosphonates have shown some effect in adults, but not in adolescents. So I alluded to kind of the role that estrogen plays. So estrogen helps with bone mineralization. So in our biological females with malnutrition who develop amenorrhea, they are in a low estrogen state. And as a result, they will have failure to accrue normal bone mass. And as a result, you can see lots of complications. On the slide are 2 studies that illustrate this. So in the first study, they found that patients with anorexia nervosa had osteopenia and met criteria for osteoporosis. And a cross-sectional study where they compared females with anorexia nervosa to normal weighted controls, those with anorexia nervosa had a higher lifetime prevalence of prior fracture. And finally, this is not a system per se, but patients with malnutrition can have deficiencies in vitamins and minerals. So zinc has been shown to be deficient in patients with anorexia, and zinc serves a lot of purposes in the body. One that's really interesting is it's involved in sensation of taste and smell. So you can imagine if you're deficient in zinc and your sensation for taste and smell is impacted, you're going to have a hard time wanting or desiring to eat. Zinc supplementation has been shown to increase recovery rates in anorexia and decrease depression and anxiety. Methylmalonic acid is a marker for B12. It's more accurate to measure MMA levels as opposed to B12. And as a result of that deficiency, patients can sometimes develop neuropathies. So for those of us who take care of patients with malnutrition in the inpatient setting, we often assume that patients are deficient and we supplement them and don't check their levels because the tests are expensive and to supplement it's safe and it's actually cheap. And the outpatient level, you can consider giving patients thiamine as well as consider giving zinc or oftentimes we just use a multivitamin that contains those minerals. So this side is a little bit busy, but I just wanted to show kind of the mechanism of starvation, and I'm going to talk through this. So starvation induces protein and fat catabolism, which leads to loss of cellular volume and function, thereby resulting in adverse effects and atrophy of the brain, heart, liver, intestines, kidneys, and muscles. Specifically, the metabolic response to starvation is characterized by a switch from carbohydrate metabolism to fat metabolism. And you really are going from anabolism to catabolism. Initially, stores of carbohydrate precursors like glycogen are depleted. And then within 24 to 48 hours, there's an increase in gluconeogenesis from amino cells and glycerol. Subsequently, a ketogenesis takes over, and much of the body's metabolic needs are met by ketone bodies and free fatty acids. This is a consequence of decreasing insulin levels and relatively increased influence of catecholamines and cortisol. And over a prolonged period of starvation, protein catabolism begins, and then you'll have muscle breakdown. So I don't know how many of you guys have heard of refeeding syndrome. I kind of alluded to it a little bit earlier in the talk, but this is the major complication that we worry about, those of us who care for patients admitted with malnutrition. What is refeeding syndrome? It's a metabolic derangement leading to fluid shifts and organ dysfunction, and it happens when severely malnourished patients start getting aggressively renourished, and it can be life-threatening. So this is why sometimes you cannot start the refeeding process as an outpatient, and the patient needs to be admitted and monitored in the hospital. So this animation that I'm going to go through was done by a former fellow that I worked with, and it beautifully illustrates what refeeding syndrome is. So when someone is severely malnourished, their total body phosphorus levels are depleted and low. Then you start to feed them, and the body's like, great, we're getting food. So glucose increases, and as a result, you have an increase in insulin. As a result of that increase in insulin, you'll have intracellular entrance of potassium and phosphorus. And we are already in a low phosphorus state to begin with. So that's going to lead to further electrolyte disturbances. So you'll see hypophosphatemia, hypokalemia, as well as hypomagnesemia, although I haven't seen that as often. Then the body is switching from catabolism to anabolism. And as a result, you're going to start making ATP. So body's like, great, we can make ATP, and it's going to gobble up all that phosphorus, and we're already deficient. And so you're going to have further depletion of phosphorus stores. And then that's going to lead to tissue hypoxia and organ dysfunction. And then additionally, that increase in insulin is going to result in an increase in sodium resumption, but there's dysfunction of the renin angiotensin aldosterone system, and that's going to result in fluid retention, and that's going to be the edema that we see with refeeding syndrome, pericardial effusions, pedal and sacral edema. So with all those complications that I just went through, oftentimes it's not uncommon for patients to have to be admitted to the hospital. So I wanted to talk through that with two cases. So the first case is patient DM, and he presented in August of 2020. I actually was on call for our group, and I got a call about him. And the story was, I was just trying to get healthy. And so what I was told was that he had lost weight over 8 to 9 months. And as you can see from his growth chart, it was about a 15.3 kilogram weight loss. So pretty aggressive amount of weight loss. How did this happen? So he was restricting and hyper exercising, and it got worse during the pandemic. Then there was increased rigidity about caloric intake, and his family could not redirect him. So when I heard this story, I was like, to the ER you go. And so he presented to the UVA ER, and this is what he looked like. He was bradycardic with a heart rate of 35 and had an irregular rhythm. He was hypothermic, and he had hypophosphatemia. That same month, I was on call again, got another call about another patient who was in the office with the PCP, and she told the PCP she hadn't been feeding herself well. The PCP, she had bradycardia, and this was in the setting of weight loss. And when I looked at her growth chart, you could see that her BMI dropped from the 50th down to the 10th percentile. Her EKG in the office was significant for bradycardia with PACs. She had a history of caloric restriction and hyperexercise that worsened during the pandemic. She was struggling with body image since 8th grade, and she had secondary amenorrhea with an LMP of August 2020. So I heard that, and I said, please send your patient to the ER. And in the ER, her EKG was significant for sinus bradycardia. So which of these patients should be admitted to the hospital? Throw in your answers in the chat. Yeah, everyone's got it. Both of these guys meet criteria for being admitted. So on the slide are the criteria that adolescent medicine physicians practicing in the US use as indications for medical admission. In the case of our two patients, these are the criteria that they met. So for patient DM, he had physiological instability, namely severe bradycardia, hypothermia, electrolyte disturbance, and hypophosphatemia. And patient SH had physiological instability, namely severe bradycardia. From the perspective of our psychiatry colleagues, here are indications for admission, and this chart is from the 2023 practice guidelines of the American Psychiatric Association practice guideline for the treatment of patients with eating disorders. General categories for admission are having abnormal vital signs, having abnormal laboratory values, and then other mental health issues such as acute food refusal for 24 hours or suicidality. So we decide that a patient needs to be admitted. It's really important that we are very clear about the goals of medical admission, not only for the medical team that's taking care of the patient, but also for the patient and the family. So what are the goals of a medical admission? It's really safety, and we do this through monitoring, specifically cardiac monitoring. These patients will be on telemetry. We really like to see how low their heart rate goes, especially at night when they're in deep sleep. Checking vital signs, monitoring input and output, and looking at the behavior. So what is the eating behaviors like? If there's a history of purging or hyperexercise, trying to kind of monitor that and then break them of the pattern, and checking labs to avoid refeeding syndrome. We particularly look at the phosphorus levels, and then we make careful adjustments in the nutrition plan to avoid refeeding syndrome. So we're normalizing vital signs. We are also stabilizing eating patterns by getting our patients to eat on a schedule, eat regularly, and not go for long periods of time without eating. And we do this by creating a standardized nutrition plan that has calories that are advanced at a reasonable rate that is not too slow, but not too fast to induce refeeding syndrome, to an appropriate caloric goal. We like them to take that by mouth, but if they need assistance of an NG tube, we will do that. And then judicious use of fluids, especially if a patient is showing signs of hypovolemia. And then we take the time to think about next steps. What's appropriate treatment? And what I really want to emphasize is being admitted to the hospital for malnutrition is not treatment for eating disorders. We're starting the process by getting them on a path for weight restoration, but treatment is a whole different thing, and Dr. Stevens is going to talk about that shortly. But is this something that we can do as an outpatient, or is the patient sick enough that they need to go someplace else for treatment?
Yeah, so I'm going to talk a little bit about what that treatment looks like. It's recommended to have a multidisciplinary or interdisciplinary treatment team that's consisting of at least a medical provider, a mental health therapist, and a dietitian specializing in eating disorders. We have this team. Open and frequent communication between team members is very important. It's important for the team to be on the same page with recommendations. Mixed messages for the treatment teams, a recipe for disaster. Oftentimes individuals with eating disorders do not want to gain weight. They do not want to stop these behaviors. If they get any messages that are contra indicating to what the eating disorder wants, they'll follow that one. It's important to stay in your discipline's lane. So if you need to answer a question outside of your role, either reiterate information from the latest communication or tell the patient they need to ask that provider. For example, if they're asking about the meal plan, like that's a really great question for your dietitian. And if your patient's in eating disorder care outside of your practice, directing all questions about the eating disorder care to the eating disorder team. To break down those roles a little bit more, so the medical provider is focusing on the medical monitoring, everything that Dr. Louis Jock just went through, and managing those medical consequences of disordered eating. They do weights and vitals in clinic. We do blind weights because it can maybe anxiety producing for people with eating disorders to know their weight in the early stages of treatment. So we generally don't discuss weight with their patients. We also advise family members to remove scales at home. Mental health therapist provides individual and family therapy for eating disorder and the comorbid psychiatric diagnoses, managing and treating the psychological aspects of eating disorders, discussing and monitoring goals, and the dietitian providing nutrition education, creating meal plans that meet nutritional needs, and working with patients and their families to work towards those goals. So this chart is just great overview to look at what we mean by all these different treatment levels. So outpatient programs are where the patient engages in outpatient appointments with therapy, dietitian, physician. Intensive outpatient is kind of the next step up. This is typically 2 to 3 times a week. It's up to 4 to 5 hours a day. This includes individual therapy, group therapy sessions, meal support, and hopefully family involvement if it's an adolescent. PHP is similar to IOP, but it's more extensive. So it's 5 to 6 days a week for 6 to 8 hours. And then residential is kind of the highest level of care that you can get in terms of therapy services. So it's around the clock 24-hour care. And as Dr. Louis Jack mentioned, we do also have inpatient medical stabilization, which is really just designed for short-term medical stabilization. At UVA, we provide outpatient care and inpatient stabilization. We have to refer out for IOP, PHP, and the residential programs. So that's our perfect world. We know that having access to all those different treatment levels, treatment choices are constrained by insurance options. Insurance dictates what provider or facility a person can go to. Also available resources. There are limited providers with specialization in eating disorders, especially ones that are in network with insurance panels, and especially ones that accept state-funded insurance. And then motivations. If it's an adult, they do have to consent to treatment. And if it's an adolescent, parents have to consent to treatment. So here are the evidence-based treatments for adolescent eating disorders. Current guidelines recommend family-based treatment, or FBT, as the first-line approach for adolescents with eating disorders. So I'm going to spend some time talking about this one more in depth. Adolescent-focused treatment, it's considered a second-line approach, and it's an adaptation of FBT. In FBT, the main strategy is to empower parents to increase caloric intake and support weight gain in the child or adolescent, versus in adolescent-focused treatment, the main strategy is empowering adolescents to help them manage life without resorting to eating disorder behaviors. Parents are still involved and they attend sessions as needed, but it's more flexible than FBT. And then enhanced cognitive behavioral therapy, or CBTE, does not require parental involvement. It's the first-line approach for adults with eating disorder, and it's been adapted for use with adolescents who don't have parental involvement in their care. And I'll touch on that briefly. So FBT, the importance of family support and involvement in the treatment of adolescents. It improves treatment outcomes. Again, the most evidence for FBT is for patients in the early stages of illness, highlighting that importance of early identification and treatment. So one thing that providers can really do to help is to advise parents that they should be included in the care of their child and find a therapist and dietitian that includes families. Oftentimes a therapist or a dietitian may treat eating disorders, but they don't have that adolescent piece and don't necessarily routinely involve parents in appointments. And I will say that there are challenges with this approach. Many families don't necessarily have the time, financial, or emotional resources to implement it. And it is contraindicated if there's abuse or abusive family dynamics. So to break down the key features, first one is that, again, we empower parents and caregivers to take charge of restoring the adolescent's health. The assumption is that parents or caregivers are the best resource for recovery. We externalize the eating disorder, so the adolescent is not to blame for the eating disorder, but we view it that the illness or the eating disorder has taken over their mind and they're not able to make recovery choices on their own. So the goals are to have the caregivers and the adolescent team together to fight the eating disorder. It can be helpful to name it. Some adolescents call it Ed. I've also heard Bob or Karen or other really creative names. FBT is also agnostic about the cause of the eating disorder. As mentioned, we recognize that what causes eating disorders is multifaceted and there's a perfect storm. I often look to patients and I say, I know that you didn't wake up and choose to have an eating disorder. And parents, I know that you didn't cause this. It's really complicated. We'll likely never know what caused it, but we can recognize what's maintaining it. And then we focus on those behavioral changes, such as eating enough in a consistent manner and stopping other eating disorder behaviors through different supports. And so here's a breakdown of our phases of FBT. Phase 1 is always nutritional restoration. We talk a lot about food is medicine, where parents and caregivers are in charge of food choices, the quantity, and they prepare all meals. If we don't make progress in this phase, this is where inpatient medical stabilization may occur or referrals to higher level of care. I like to give adolescents hope that phase 2, we always return control of eating back to the adolescents or temporarily giving it to parents, and then we return it back in a developmentally appropriate manner. And this occurs when the adolescent's eating a wide variety of foods and is feeling more comfortable with eating. And we do suggest that caregivers gradually hand back control of food with support still in place. And then phase 3, we have treatment completion and address other mental health issues that may be there, that may still be present. We're also working with the adolescent to establish an identity without the eating disorder and return to normal development. I'm not going to go into detail about the meal plans, but I did want to share this with you. We use what's called the plate-by-plate approach, which is a structured meal plan, but it's flexible and it's designed to be simple. So there's not a lot of calorie counting or exchange counting or some of the other systems that have been used in the past. So we advise parents to choose a 10-inch plate. They fill it with 50% grain, 25% protein, 25% fruits or veggies, plus fat and also dairy on the side. Fill the plate, eating every 2 to 4 hours. And we encourage parents to not honor eating disorder preferences. And by that, we mean choosing foods that the adolescent ate prior to engaging in disordered eating behaviors. Typically, meal plans look like 3 meals and then 2 to 3 snacks as well. As mentioned, FBT can be really difficult, but it's also really effective. A lot of the work that we do therapeutically is building up parents' confidence and implementing this approach. I really like this quote that was written by a young woman who had a severe eating disorder in her teenage years. And this is what she wrote for her parents. So I think most importantly, I would tell them and any parent whose child is in the beginning stages of an eating disorder, not to wait until that person is ready to get better, not to buy into the idea that until someone wants it, there's nothing anyone can do. When someone is drowning, you don't wait for them to clearly articulate, I'm having trouble swimming. Could you please come in and help me? You just dive in and you grab the person and you would try and get them out of the water, even if they're kicking and screaming. I would encourage them to keep going, not give up, regardless of how hard I fought back. So I did want to talk a little bit about some of the other approaches that are different from FBT, including CBTE. So it was designed to treat adults in the outpatient settings and then adapted to treat younger patients. The evidence for its use is in anorexia, bulimia, and binge eating disorder. It's personalized to match the eating disorder psychopathology of the individual patient. And it's also a transdiagnostic approach where it's hypothesized that the main maintaining factors of the different eating disorders are largely the same, which is an over-evaluation of control over eating, shape, or weight, and then various disordered eating behaviors that stem from that cognitive process. So we work to encourage regular, consistent eating with the help of a meal plan and use problem-solving techniques to increase adherence to the meal plan and reduce eating disorder behaviors. Then we spend also a lot of time challenging eating disorder cognitions. The treatment with the most evidence base for ARFID is cognitive behavioral treatment for ARFID or CBT-AR. It combines the tenets of FBT with cognitive restructure and exposure principles from FBT. The main treatment goals are to achieve and maintain a healthy weight. So we have people restore weight if it's needed by increasing preferred foods, eating on a schedule, and having that family involvement, correcting nutritional deficiencies, eating from the 5 basic food groups, and feeling more comfortable in social situations with food. And there's 3 stages: psychoeducation about ARFID, understanding nutritional needs, and incorporating new foods. And we incorporate foods using exposures to reduce fears around eating through strategies like food chaining, exploring food with the 5 senses. Regardless of treatment approach, it's important to acknowledge the many different aspects of recovery from an eating disorder. Full recovery from an eating disorder includes medical stabilization as step 1. So as patients achieve this, medical appointments may be spaced out, but there's still much work to be done. And that includes a return to normal physical growth and development that allows the adolescent to achieve their growth potential. One reason that we don't share goal weights for patients is because that goal target often changes as adolescents continue to grow and develop. We don't want them stuck on a specific number. We want them to eat a wide range of foods without anxiety or guilt, having freedom from eating disorder thoughts and preoccupations with food and weight, being able to eat spontaneously and independently when hungry, and going back to participating in activities that they used to enjoy, such as school, socializing with friends and family, engaging in sports or other activities. remind patients and their families that recovering from an ED is a marathon, not a sprint. It's not linear. There's going to be ups and downs, but we believe that they can achieve a full and lasting recovery. And every step of this, regardless of how sick or dire a case may seem, we try to instill hope because it is incredibly powerful. What about comorbid psychiatric diagnoses? Psychiatric comorbidities is the norm, not the exception. Between 1/2 and 2/3 of adolescents with anorexia have a comorbid psychiatric diagnosis. Major depressive disorder is the most common, and it predates the eating disorder in about half the cases. OCD is also high for girls and boys, and it tends to predate the eating disorder, and it also results in poor outcomes at follow-up. Most comorbidities are exacerbated by the eating disorder, and focusing on eating disorder recovery should almost always be the priority. And here's a really cool study that highlighted this. So they had adolescents with anorexia enrolled in an RCT comparing two forms of FBT, and they completed the mini international neuropsychiatric interview for children and adolescents at baseline and the end of treatment. So at baseline, 53% of participants met criteria for at least one comorbid psychiatric diagnosis. And by the end of treatment, so just focusing on eating disorder treatment, renourishment, this number reduced to 26%, so in half. We want to switch gears to briefly talk about prevention efforts. To do this, we need to first talk about some of the issues that we face. Again, eating disorders are multifaceted, genetic, psychological, social, environmental components that interact together. And there is clear evidence that we are influenced by our environment and what research calls the tripartite influences: media in all its forms, friends, and family. And these influences lead to negative body image, which is a major contributor to the development of an eating disorder. I just have some examples here of some brief things that our adolescents and all humans see. I'd be remiss to not talk about social media. So there's a growing and strong body of research suggesting that social media use is linked to eating disorders due to increasing negative body image, and it does this through a variety of mechanisms. One powerful one are filters. Below are some examples. One's more subtle and one is much more dramatic. Both Instagram and Snapchat platforms have beauty and augmented reality facial filters. Settings like the enhance feature on TikTok and touch up my appearance on Zoom deliver flawless skin for videos. Editing apps such as Facetune allow users to smooth, shrink, and sharpen their way to perfection. It's never easier to picture your ideal face and see the flaws in your actual face. I really love this quote that says, "Before social media, the source of our insecurity was failing to meet the beauty ideals modeled on magazine covers. Now we compare ourselves not only to an airbrushed elite, but to our airbrushed peers and our airbrushed selves." Additionally, online health and wellness content on social media may have negative consequences for users. Messages about weight management through diet and exercise are shared widely and receive high levels of engagement. What I eat in a day is an example. It's usually very restrictive. A glow up shows a before and after picture of a person, usually with dramatic weight loss. And this last picture are some screenshots from TikTok. I want to talk a little bit about TikTok because it has a really strong algorithm that rapidly identifies a person's interests and can send adolescents and others into harmful streams of content that can trigger an eating disorder. These algorithms are really good. They can pin down age, gender, and interest rapidly. And it's fun being delivered content that's so in line with our interest, but sometimes our interests are not self-protective. For example, adolescents may start watching a video about a sport they like, which leads them to a what I eat in the day video for people trying to maximize their training in their sport. And that sends them to someone who posts a video about their eating disorder, and then they engage with that content. So the more you watch this, the algorithm identifies the area of interest and sends more and more content, such as diet and exercise and potentially harmful pro-eating disorder content. And the same phenomenon is happening with intentional self-injury, suicide attempts, depression, and other mental health concerns. And consuming this content normalizes really dangerous behavior, and it can also glamorize these mental illnesses. So understanding the dangers of social media and smartphones, this can lead to some prevention efforts. This new book I have here, The Anxious Generation by psychologist Jonathan Haidt, outlines some really important steps that we can take to protect our kids. So we can advocate to get phones out of school, advising parents to keep kids off smartphones until they're at least 14 years old, advise parents against social media until they're 16 years old, and have open conversation with teens about social media and their impact on mental health. Another danger that's perpetuated in our society is diet culture. It's a society that focuses and values weight, shape, and size over health and weight well-being. It does this through a variety of mechanisms, weight loss challenges at work, etc. So again, kind of educating kids on these matter. They're marinating in this culture. We want to give them the tools to combat it and challenge it. And some ways that we can do that is increasing representation of all body sizes and shapes, using body neutrality, such as challenging stereotypes that thin bodies are good and large bodies are bad, educating yourself on size discrimination and thin privilege, decreasing focus on weight for every child and adolescent rather than pulling up the growth curve. Talk about like you're really growing great. Decreasing focus on appearance, not commenting about appearance, whether it's positive or negative, give compliments about who the person is or what they're doing, and not making assumptions about people based on their body size and shape. It's also important to neutralize our language around food. In our clinic, we work really hard to challenge the beliefs that there's good or bad foods or healthy or unhealthy foods. And when discussing diet, we really talk a lot about eating enough, knowing that the number one trigger for overeating is hungry. We discuss adding in all food groups rather than cutting out, and noticing what food groups may be missing. And this is in line with Health at Every Size, or HAES, which you may have heard about. It's a movement to promote size acceptance and weight discrimination and lessen the cultural obsession with weight loss and thinness. It promotes balanced eating, life-enhancing physical activity, we call it joyful movement, and respect for diversity of bodies, shapes, and sizes. So there's no focus on weight or emphasis on weight loss for improved health. I'm not going to go through the slide. I have it here for reference, but there's a lot of different ideas about how to change some of your talk about food and weight, especially for someone struggling with an eating disorder, and how to change it. So we wanted to leave you with some information about referrals for outpatient providers. At the Teen and Young Adult Health Center, we provide an interdisciplinary initial assessment where they meet with a therapist, a dietitian, and an adolescent medical physician to provide the assessment and then give feedback and recommendations to the family. And then we provide outpatient care follow-ups, and we refer to higher level of care as needed. You can search through some individual professional organizations here. And there's also some new virtual options, such as Equip Health or Within Health for individuals with private insurance.
So to end, when in doubt, phone a friend. So there's always an adolescent medicine physician who's on call for our group. So if you have a patient who's concerning you or you have questions, feel free to call UVA and have us page, and we'll do our best to answer your question. We really can't give specific medical advice without meeting a patient, but we can kind of direct you and say, actually, I think you should just send this patient to the ER because it sounds like they need medical stabilization. Additionally, DC Nationals is a good option as well. They have adolescent medicine physicians on staff as well, and they have a little bit more robust inpatient mental health services. So this can be particularly helpful for patients with a lot of comorbid psychiatric illnesses, or maybe not a lot, but serious comorbidities. And finally, VMAP is a great resource to ask questions about how you can keep your patients safe until you can connect them to the appropriate level of care.
And we've left you just with some resources. I think you'll have access to the slideshow, and we'd like to open it up for any questions you all have.
Any question from our great presenters tonight? Please speak up.
And I just want to apologize. I didn't realize my video was off, so I apologize for that.
Let me ask our two speakers something, and I shared this with then when we did our test connections, Danville, the Danville community has been an NIH study center for several years through their so-called EDUC program, which was developing local programs to effectively improve public health. We had one a number of years ago nicknamed Dr. Chip, Dan River Cardiovascular Health Initiative Program, in which we found so many of the middle school children here with excessive body weight, and many of those, well, 10% at least, had clinically significant hypertension. When our providers see the patients where the issue is excessive body weight, short of referring them to a wonderful comprehensive center like you have, and which other local children's hospitals have, what should they be? What is the quick and thing they should do first when they're dealing with excessive body weight in again adolescents that come into the clinics?
So, I mean, I think it's important to acknowledge, but I think you can get yourself into trouble if you start focusing on numbers. So if you notice that your patient's BMI is quite elevated, I think this is where you say, you're getting a history. Maybe they're there for a well visit and you get a dietary history. And that dietary history might tell you a lot about what is the cause for that. And then you kind of, with the patient and family, say, I've noticed that, you're, based on our conversation, you're eating a lot of fast food or you're not engaging in a lot of physical activity. I'm concerned that you're not living the healthiest lifestyle you can. And then to kind of take it from there, instead of focusing like your BMI is at the 99th percentile, or your BMI is at the 107th percentile. And therefore, I think you need to lose weight, because then what ends up happening is, what is a good BMI? How much weight do I have to lose? And it's a really difficult question to answer.
Right.
Yeah, I think the one thing I would add to that as well, and one thing that's a really big shift, and what Dr. Libby Jock mentioned, is that weight alone is not the end of the story, right? So starting to have a conversation of, how are you feeling about how you're eating? And even trying to check in their engagement, if do they view it as a problem? And again, individuals in high body weights, even high body weights with hypertension, can still have eating disorders. So sometimes individuals are engaging in periods of restriction and binge eating, and that might be one of the primary causes that's resulting in some of this weight gain.
Sure. Large folks can be malnourished, no question about it. Absolutely. Any questions from all the nice folks on the call tonight? Questions, comments, or concerns as we ask the residents when we gather? Okay, well, I appreciate everyone being on the call tonight. Mary and Camilla, and thank you for participating in the Sovah Health CME program. We're actually right on time. Both of our speakers worked very hard this week to tailor their presentation to our 1.5 time period. And I must say they've done an excellent job with that. We are so grateful for them and the good folks at UVA who's helped us put together this program and the one we'll have in 2 weeks. And we hope you'll be back on that call. You can register through the same, if you will, link that Mary distributed to most of you that allowed you to register for this program. So in 2 weeks, we'll talk about GYN problems and adolescent girls, women, and we'll also talk about mental health issues that we touched on a little bit tonight, but they'll go in a deeper dive when we gather that time. So as we always remind the residents, please be careful out there. We thank you for being here. We hope everyone has a great evening. Thanks so much. Bye-bye.